what can we do to start? Well, there are plenty of things. Even if we don't have a cure, we have a management of Duchenne muscular dystrophy. We have teams to work together to give these kids and these families the best future we can. So we have already discussed a little bit about steroids, and I think that it's important to emphasize at the very first meeting that we have today treatments that works in Duchenne muscular dystrophy, that does not stop Duchenne muscular dystrophy, that does not cure Duchenne muscular dystrophy, but that brings significant benefit to the child. And obviously, physiotherapy and management, global management, how to live with Duchenne muscular dystrophy is something that we need to start discussing at day one. So we will go later in more detail about steroids, but I think it's important to explain the families first the benefit, because that's the treatment today that works the best. And then it comes with side effects. And the way personally I present the side effect is there are some side effects that we can manage quite well, in my opinion, and some for which we are not that good. We do our best, but we have to accept at one point, and we need to consider steroids as a balance, right? And this balance can change during life, and the side effects can be very different according to how long the patient has been exposed to steroids. The benefit is definitely that steroids delay the progression of the disease, it delay the loss of ambulation, and at further step, it delayed the loss of upper limb function and the decline in respiratory function and slowing the progression of cardiomyopathy. These patients live longer in a better condition. It also delays or prevents scoliosis. And since we treat these patients with steroids, we have much less patients who have to go to spinal fusion. We also know that the optimal timing of steroids initiation is not exactly known, but we know that if it's too late, it's too late, and we should probably start before the age of 5 or before the age of 5 years. There is not a huge level of evidence, but there are some, and then should we start at the age of 3 or 4? It's still unclear from the literature. And then we have several different regimens of steroids, and today it's mostly either prednisone, either deflazacort, but there is a new steroid that is just approved. It's called vamorolone, and it could potentially have less side effect, especially when it comes to bone health and to growth. And there are several ways to prescribe steroids, right? You can give it every day. You can give it 1 day on, 1 day off, 10 days on, 10 days off. Sometimes just during the weekend. It's we are pretty sure now that giving it every day is the most efficient way, but it comes with a cost, and the cost is the side effect, right? In the young kids, the first side effect is behavior, right? It can make them quite nervous. But then come other side effects, and one of them, which is probably the one for which we are the most, we have not so much action, is the delay in growth. And these kids are small, and they can suffer from a psychological perspective. To be small, for them sometimes is worse than to be weak, and we have to appreciate this as doctors and parents, because we sometimes very proud and very happy of the effect of steroids, but we need to appreciate what it really means, this balance from the child perspective, and not only from our HCP perspective. Another one is certainly bone demineralization, for which we have some possibility to act on. And an important one in the future, when the kid will become a teenager, is the delayed puberty. And we should not underestimate the importance of puberty for these kids. We have treatments that are approved But we also have trials, and we have drugs that are approved in the US or in the EU and not on the other side of the ocean. So yeah, would you be happy to bring us into the different trials approach for Duchenne muscular dystrophy?
Will not venture into going into detail in each one of them, but just to explain the principles that trials have taken. So one approach is targeting the muscle fibrosis, necrosis, and looking at approaches that reduces that and subsequently reduce the progression of the disease. And falls under that. Obviously, we understand glucocorticoids work, as Laurel mentioned, but we don't know all the mechanism by which it works, but we know it works on inflammation and fibrosis in the muscle. But there are other approaches that work on that element of the disease that are either in trials or had preliminary approvals. There has been many other trials that, for example, targeting myostatin or using things like tamoxifen and trying to see if using other drugs can have any effect. And some of these got stopped sometimes because just the primary endpoint wasn't reached. Now, the other approach is targeting the primary. So we have a protein that is either absent or truncated because of the mutation, and targeting that protein production via approaches to different stages of the making of that protein. So this is where exon skipping, for example, comes into play, read-through therapies and gene therapies. And I'll explain a little bit more about that in the next few slides. So vamorolone is a synthetic steroidal drug that is similar to prednisolone, but differs in a couple of binding sites. So the idea is maintaining the anti-inflammatory effect of glucocorticoids, but not maintaining some of the metabolic effects responsible for the side effects. It's been approved in some countries and being appraised in some others. It's a liquid medicine that is taken once a day orally. So that might come into play in treating children as we in the near future. And then if I move on to the other side of that chart where we talked about approaches to target the protein production. And this little diagram show the stages and where targeted therapies. So gene therapy, for example, is targeting the primary gene mutation, whereas exon skipping is where the target is the pre-messenger RNA during the splicing process and modifying how the protein production is made. And there is a couple of slides to explain those approaches. So with exon skipping, for example, if you look in the middle of this slide, if you are missing an exon that has caused out of frame deletion, as we explained earlier, the exon skipping approach uses an antisense oligonucleotide. So this is a particular RNA series that will bind to the next exon. So they have a deletion of exon 52, and you have an antisense oligonucleotide that binds and hides the exon 53. And the theory is that then that restores the reading frame of the dystrophin messenger RNA, and ideally leading to a full dystrophin protein production. So this is the approach with exon skipping. This is drugs that are delivered once weekly by IV infusions. And then the next step from that is actually gene therapy. And as we explained earlier, this is the dystrophin gene is one of the biggest genes in the body. So packaging it in a viral shell is very difficult. And the idea of microdystrophin came from the knowledge that some people may have a very large dystrophin mutation, but still have a milder phenotype because they had an intact reading frame, or a reading frame that was maintained. And that's the approach used for microdystrophin, where the reading, it's a shorter gene, but maintains the reading frame. And different companies have different programs with different with different viral vector. And some of the programs have been approved in some countries, and some more trials are coming as we go along. And this is mainly targeting, obviously, the gene itself, the gene defect. Um, and more treatments are being looked at, approaching both sides, whether that's protein production or inflammation of the muscle. The treatments need to be safe but also effective, and the side effects need to be tolerable and manageable, and don't add any additional burden.